So I'm going to be talking about traumatic brain injury. So beyond the bruise, the LVT's role in TBI. I have no conflicts of interest. Just a quick objectives. We're going to talk a little bit about pathophysiology, clinical signs, diagnostics, patient care, and then treatment. And then if we have time, I have a little bit of a case after that we can go through, and you guys can ask me some questions and stuff like that. So let's get into it. Pathophysiology, I know this is everybody's favorite part. It is also my favorite part as well. So just bear with us while we go through this all. So what is traumatic brain injury? It's basically the degeneration from some trauma that's happened to the brain, an external force. So there's actually two types. There's a primary and secondary, which we're going to get into as well right now. And it can have cause cognitive and physical dysfunction as well. So sorry about the traumatic pictures. We work in New York City and you get a lot of trauma going on. So your primary injury. It can be blunt or penetrating trauma. Funny enough, this dog was actually completely alert and didn't really actually have any neurologic deficits, as you would expect it would from this. Primary injury occurs immediately. This can be either penetrating or blunt. In human medicine, the penetrating trauma actually tends to carry much higher mortality, but in veterinary medicine, it's a little bit different. It doesn't carry as much mortality. And we actually see the blunt trauma more often in veterinary medicine as well. So this can be from contusions, laceration, and then you get into a little bit deeper and you have your axonal damage, vascular causing hemorrhage, edema, decreased perfusion to the brain, and stuff like that. So this is all what we see when the patient first comes in, any sort of TBI like that. Then we go to our secondary. This can happen hours to days later. So this can occur from systemic extracranial insults and intracranial physical and biochemical changes. So it's really all what just happens after that initial trauma. So it's a little bit different. These are actually, this puppy's still alive, and if you come to AMC, you can still see him, and he had some damage, but he is perfectly healthy and running around like the happy-go-lucky puppy he is at 4 years old now. So we do need to just make sure that with these guys, the big take home of this presentation is that we continue to monitor throughout the entire time. So we're going to get into a little bit of that pathophys, which is my favorite part, and actually the part that I'm most nervous about talking about. So these are all the processes. This is your actual neuron in the brain and all of that stuff. So basically, the biggest nutshell to take away from this is that the secondary injury results in impaired oxygen and glucose delivery to the neuron. And so you have decrease in ATP production, failure of cellular membrane pumps, and this leads to cerebral edema. And then you can have your oxygen injuries. This can lead to your inflammatory and your coagulation cascades, which then can lead to cellular death. And this is the biggest problem we see when we have those TBI patients. So this is a huge issue that we see that we actually need to get in pretty quickly and do some interventions. So got some fun slides up here. We can talk about them. The big thing here is the Monroe-Kelly doctrine. And basically what it's saying is everything that is in the skull and the brain in the skull needs to stay there. And you have all of this, your brain parenchyma is 80%, arterial and venous blood is 10, and then your CSF or your cerebral spinal fluid is 10. Any changes in any of that can cause issues. And if you actually look at that slide, wait, I have this. Does it work? Oh, here. So this is actually a case we saw, and it was a really cool case. This is the normal brain that we did an MRI on. And then this is the next day, the dog was still alive. And you actually can see the herniation right here. So this is your skull, your brain, same thing, but then you can see the herniation right there. And that's because for this one, it had such bad cerebral edema that it actually herniated its brain. So this is actually probably we don't get these a lot because typically after this happens, unfortunately, they are not going to do well, but this owner wanted to continue. And so we did another MRI. And so we actually got this picture, which was actually very informative to all of us to see truly what's going on with this. So this was probably one of the cooler things we've done in a while, at least to me as a nerd. So the biggest thing is you want to keep your cerebral perfusion pressure. It's actually really nice having this thing. I didn't even realize we had it. You want to keep your cerebral perfusion pressure. You want to keep this at the exact numbers they need it. And then what does that is your MAP and then your intracranial pressure. Can we really measure intracranial pressure in veterinary medicine? No, we don't do that. But we go a lot by the patient's systemic blood pressure. So keeping that normal, we typically know that this can stay in the normal ranges. If there was a way to do it, I think the AMC would actually try. But your systemic blood pressure actually can lead to the hypertension. This is what can lead to the actual patient death, and then the herniation we have up here. So then we go into more cerebral perfusion pressure. The sort of take home of this slide is that very small changes can actually cause big problems. So this chart shows your relationship between intracranial pressure and intracranial volume. Initially, when there's like a small increase in the volume, they can have a compensatory reaction where it can keep everything normal. If it goes up even more, that's when you're going to start having your herniations. So once that critical volume is met, that's when you're going to have that herniation of your brain. And so that's what we need to try to keep under control. And there's definitely different therapies that we do to keep that under control. Help. Okay, don't touch that. No. Okay, so more pathophys, it's my favorite thing in the world. The pressure and autoregulation refers to the normal brain to maintain cerebral blood flow over a wide range. So it can be, your MAP can be anywhere between 50 and 150 and everything stays normal, which is a good thing to know. So above this range is when you start actually seeing potential issues, especially in the TBI. Okay, the next slide, and this to me is if you remember anything out of this lecture, this is the most important thing because it doesn't just have to do with traumatic brain injury. So just get into it for 1 second. Your preload, your contractility, and your afterload, this all helps to get your stroke volume. Stroke volume times heart rate equals cardiac output, okay? Your blood pressure is your heart rate times your cardiac output. Any changes in any of these can decrease your cardiac output, which will decrease your blood pressure, which will decrease oxygenation to the body. This is the most important thing. For our talk here, the brain actually takes about 15 to 20% of the resting cardiac output. That is a huge number. So shock, anything that decreases your cardiac output can decrease your blood flow, can decrease your oxygenation. That is the big take home for any technician from this lecture and in general. So this is very much something to remember. We use this under anesthesia, we use this in ECC, we use this everywhere. This is the foundation. Okay, back to more neuro stuff. Okay, so when we talk about having more fluid or cerebral fluid and edema on the brain, we're talking about neurogenic pulmonary edema, which is just another form of non-cardiogenic pulmonary edema. Your CNS results in a massive sympathetic outflow that causes pronounced vasoconstriction and systemic hypertension. These are the things we're trying to avoid with our patients, and we are trying to avoid this whole cascade that can lead to your neurogenic pulmonary edema, which can then lead to your patient having a herniation. So we are trying to avoid all of this, and we will get into a couple treatments later because those are important that you guys know what those treatments can actually do for your patients. Okay, so we're gonna get into some clinical signs, and as technicians, this is the most important thing because we are gonna be the ones who see the patients first when we triage them. So knowing what to do and sort of what these different clinical signs mean are actually very helpful for us. We have a couple different postures for patients. This is decerebellate rigidity. You're gonna have, as you can see, your thoracic limbs and neck extended. So that's what's happening here with this cat. And then you're gonna have here, and it doesn't always have to be, but you're gonna have a flexion of your pelvic limbs. The way to distinguish this from there's two other ones. The way to distinguish this is your mentation is typically not affected, and then you're gonna have a cerebellar lesion, including herniation. Obviously, when they're herniating, that's gonna be affected, but if they're not herniating at that time, their mentation typically should be normal. Prognosis for this, not good. So then we have our next one, which is decerebrate rigidity. You're gonna have your extension of your thorax and your pelvic limbs. The difference is they're typically in stupor or coma, so they're not knowing what's going on at this point. And this is gonna be a lesion in your cortical to midbrain. Prognosis, grave. This is the most common one we see in veterinary medicine, Schiff-Sherrington's. This is gonna be extension of your thoracic limbs and then your pelvic limbs here. They're gonna be drawn under. Mentation is normal. This is typically a thoracic or spinal lesion. At AMC, we actually typically see a lot of neuro cases that come in like this. They are pretty much going to be normal mentation. And this is actually prognosis pretty good. The big take home for the last 3 slides, if you see a patient in any one of these, get a board and put them on a board immediately. You don't know if they have a fracture in their neck, a fracture in their spine, and you do not want to manipulate that in any way, shape, or form. Put them on a board. Move that board with that patient. Make sure they are strapped down to that board. That is the most important part. Okay, so then when they come in, more clinical signs, what do we do next? Well, we do a modified Glasgow Coma Scale. This is modified off of the Glasgow Coma Scale that we use in people. This is what we use in veterinary medicine. We use this in our canine and feline patients. So we basically tally this all up and we go through all these different things and we figure out what their score is. A score of less than 17 is predicted of a non-survival. It is an 82% sensitivity and an 87% specificity, sorry. As you can see here, a score of 15 to 18 is associated with a good prognosis, 9 to 14, guarded, less than 8, grave. So these are actually pretty important here, and then we have a paper where the coma scale came out with. But this is what all of the doctors, when they're doing it, this is what they're going through, and as technicians, we also should be looking at this and understanding this and being able to assess this with our patients, especially in the ICU. Okay, so then what's another thing that we look at when our patients come in for more clinical signs? Well, we're looking at a heart rate to start with. So we're gonna get, this is the Cushing's triad. So what happens here? When your patient comes in and you first see your patient, the first thing you typically notice, or I typically notice, is their respiratory rate, the respiratory effort. Then I'm going into heart rate, right? So you're gonna have a decreased respiratory rate, a decreased heart rate, and an increased blood pressure, all signs of herniation, okay? This is, and they definitely, we see this a lot with our patients, and we know, and so these are your sort of hallmark things that you're gonna see. And we will say we're having like a Cushing's triad or a Cushing's reflex. Those are sort of verbiage you will hear on a floor in a hospital. These are all marked signs of intracranial pressure on your way to herniation. Typically, you're looking at a heart rate of below 80 and a blood pressure of above 180. You can typically see this happening, I will say from a mile away, but not always. You will start seeing your patient's heart rate go down around 100, and you'll start seeing their blood pressure creep up a little bit, and then you'll also see their respiratory rate go down. So these are all things you just need to watch out for, and as soon as you start seeing this, it is a good time to let your doctor know so that we can have some interventions going on. Okay. All right, so then once we get all these clinical signs together, what do we do? What's the next thing after we start seeing all this? We're gonna need to get some diagnostics, right? So as technicians on the floor, we don't really ask for diagnostics or anything like that, but we should know what they mean and what the doctors are waiting for, right? We always wanna be 10 steps ahead of our doctors. So how do we do that? We learn. Okay, so our diagnostics. Your minimum database here is going to be your PCV total solids, a lactate, BG, electrolytes, your blood gas, and your blood pressure. With animals with a TBI, it has actually been studied that an increase in blood glucose is a decrease in prognosis. So you want to make sure that that is normal. In general, increase in lactate can be a decrease in prognosis as well. But if we can get that under control, we have a better prognosis. Blood pressure, as we just talked about, blood gas, as Daniela just talked about, is also really important because an increase in your CO2 can also be a poor prognosis. So knowing those things are really good so that you can see all those things, right? We get the printout, we bring them to our doctor. What if they're doing a million other things? You want to be able to say, hey, this dog just came in with a traumatic brain injury, its CO2 is high, and its BG is high. You want to know these numbers, and you want to understand them to talk to your doctor. Okay, so what if now the patient wants to do more? Your next things you're going to do, CBC chem, coagulation screening just to make sure that that is all normal, chest radiographs. You probably all can tell that this is a Frenchie on a chest radiograph. I'm allowed to use it because it's my Frenchie. And then you also want to get abdominal radiographs as well. Don't worry, her spine is still that messed up. Okay, so it's really important to get all these things just to know. You want to make sure. A lot of times we've actually had traumatic brain injuries come in and we find out that they have pneumonia, or, you know, off by chance they ate a sock. That's happened a few times. Okay, so then those are our basics, but then what else do we want to get? Well, you want to get skull radiographs, plus or minus, spinal radiographs, plus or minus, and abdominal ultrasound. If you talk to a neurologist, they're going to tell you probably skull radiographs aren't going to be your best diagnostic tool. Spinal radiographs, if you're suspecting any type of fracture, that'll be your best tool. But we work at AMC, and we got a lot of neurologists, and we got a lot of fancy stuff. So we go for CT and MRI. So these are going to be your best tools in your traumatic brain injuries, and this is typically what you'll see there at AMC as well. This is your gold standard. So yeah. If you're in practice and you don't have a CT MRI, yes, you definitely want to make sure that you can get your spinal radiographs to make sure there's no fracture as well. Okay. All right, my favorite part of being a vet tech, the patient care. This is where I really love to be able to help my patients out. So a few things. When your patient comes in with a traumatic brain injury, the thing you want to do is you first want to evaluate the patient as a whole. So we want to make sure their airway, breathing, circulation, dysfunction, and examination. We don't want to start with a neuro exam right off the bat. We want to make sure that our patient is overall stable before we get into everything else. Then we want to go to their level of consciousness. We want to figure out if they're normal, obtundus, stuporous, coma, or poor to non-responsive. These are all things that need to be quickly assessed and pretty much happen all at the same time. You do want to perform a neuroassessment. Typically, we will do that as technicians. We will look and perform a neuroassessment. And a neuroassessment isn't necessarily getting in and doing a full neurologic exam. Just look at your patient, right? You can assess their neurostatus from looking at them. And that's pretty important, and it's pretty important to know whether you need to get the doctor right away, and this can help you. Okay, so some more patient care. Your patients, in ICU, we do a lot of this, but your recumbent patients, you want to make sure that they are well padded, have good padding, turned every 2 to 4 hours. This will help prevent urine scald, pressure stores, limb contractions. If you turn them, it also helps them with their breathing as well because they don't get atelectasis on one side. So you want to make sure that they can be, and if they can't be sternal, you want to make sure they can be left side down or right side down. Then also, you want to check their bladder, sometimes that they cannot go on their own, so you want to be able to express them, or do a urinary catheter. Passive range of motion for these patients is also very important. If they can't move their limbs, then they just sit there and get stuck, and as we all know, that's very uncomfortable, even for us. So we want to do some passive range of motion. Oral and eye care, just make sure that you're really getting in there, cleaning that mouth out. The last thing this patient needs is to swallow extra saliva and get pneumonia. Nutritional support. It's like the thing everybody always forgets. If you talk to our head of critical care, it's her favorite thing. She's like, did they eat? Are they getting nutrition? What's happening? And she's like, get out the pericavivin, hence pericavivin. You want to make sure your patient's eating, whether or not you need to put in an NG tube or give them parenteral nutrition. They need nutrition at some point. And then pain management or sedation, right? We want to make sure that our patients are comfortable. We don't love seeing patients in pain. That's not why we got in this field. So make sure that we're doing, your CSU pain scales, making sure that they are actually comfortable. Throughout this whole time, yes, we're doing our patient care. We're making sure this all is going on. But we also need to make sure we're still assessing our patients constantly, right? They're in an ICU, 24-hour care, 24-hour assessment. So while they're there, we're going to look at different things with our patients. So we're going to look at pupil size. If they're responsive to light, we're going to evaluate for different, oh my God, my words just left me. We're going to evaluate for their pupil size, and then we're also going to see if they have a nystagmus, and this is actually a pretty good video of a nystagmus. So you can actually see that this cat, yeah. So it's like a fancy cat, not just your regular domestic short hair. So you want to look at this. So different pupil sizes mean different things. They will come in potentially with their pupil size, but also sometimes while you're taking care of your patients in the ICU, their pupil sizes will change, and that will indicate potential herniation. Again, the thing we want to avoid at all cost. So this can indicate meiosis, mydriasis, or fixed. Can also indicate different lesions in the brain as well. And that's more of on the doctor side. And then you also want to be able to notice if it's a nystagmus, if it's vertical, horizontal, or rotary. That is different things that can also help with prognosis for the doctors, or where your lesion is, or where it was potentially having that brain trauma. These are all really important things. It's nice to be able to tell the doctor, hey, I think it has a vertical nystagmus, because it just helps them go in. An extra set of eyes is always better for everything. So now that we sort of have talked a little bit about it, we need to get more into the management of your patient. Oh, okay. So big things for management of patients. You want to elevate their head 15 to 30 degrees. As you can tell, this dog, we elevated it. You don't necessarily have to measure. You can pretty much gauge if it's going to be 15 to 30 degrees. Avoid drugs that can increase intracranial blood flow, and avoid events that can decrease intracranial outflow. So you want to make sure that you're always holding your head to patient up so it can decrease. It doesn't decrease your patient's intracranial outflow, and those are where your vena cava come in. Avoid jugular compression, no jugular vena puncture, remove collars. Those can be tight on patients. If you do have to put an ID collar on your patient, make sure that it's loose enough that it doesn't constrict anywhere. We don't want to increase any intracranial pressure with these guys. Okay, so more management of your TBI. As promised, there will be a Frenchie in here always. You want to make sure they're oxygenating well, right? Their brain's not working. Means that that part of their brain isn't working well. So we want to maintain a pulse ox of above 94, a PaO2 of above 80, a PCO2 or an N tidal, 35 to 45. Different textbooks have different things. We typically go about 35 to 45. And if you need that airway to be protected to prevent pneumonia, intubate them. We want to make sure that we are protecting their airway at all costs too. There's a lot of things that go into these patients, and so we need to make sure that we're assessing all of these things at all times. You want to also prevent hypoventilation as well, because that can have issues with your CO2, which can then also cause more issues with your TBI. Okay. Continuous monitoring, serial blood pressures every 2 hours, heart rates, respiratory rates. You want to characterize that respiratory effort as well, and you want to also monitor their electrolytes and blood gases. These patients monitoring in critical condition, you're looking at every 15 to 30 minutes. In serious, you're probably looking about every hour. Fair to good condition, 2 to 6 hours, depending on the patient and depending on, do we think anything could happen suddenly with these guys? Okay. So now that we know a little bit about our diagnostics, how we're characterizing things, we want to go into a little bit of treatments, right? It's important to know what you need to have available for these patients. And also, we like to be 10 steps ahead of our doctors, should have everything out and ready to go at all times. So the first thing we always do with these guys is osmotherapy. Hypertonic saline is, at least at AMC, it's a neurologist's best friend. This can play a role in brain cell immune modulation, which may lead to anti-inflammatory effects and potential better outcomes for your patients with TBIs. Okay? In severe trauma activities, your inflammation cascade, including your systemic inflammatory response syndrome. Hypertonic saline can reduce the accumulation of extracellular excitatory amino acids, thus preventing glutamine toxicity and neuronal. What does that all mean, right? It's a lot of bunch of words and fun. They need hypertonic saline to basically decrease the amount of volume in their brain so that they don't have a herniation, okay? So we want to be able to give this to them. We will get into the next slide about, is that it? Yes. This is your typical go-to. What is a contraindication of this? Hypernatremia, okay? That is why we're checking those electrolytes. If your patient is hypernatremic, you don't want to give it hypertonic, right? Because now you're just increasing your sodium, which shockingly can also have more effects on the brain. So we want to make sure that we're monitoring things. And also, after we give the hypertonic saline, we also want to be able to monitor your sodium too. We don't want to have more effects on the brain. We want to keep it at a nice, steady place. There are different options for doses. Typically, we give a 3% dose at AMC, and that's 5.3 mils per kg. If you're going with a 7.2%, you're going at like 3 to 4 mils per kg. I typically like to just know these doses, so as the doctor's yelling out, I want hypertonic, I'm pulling it up and getting it ready for them, confirming that is the correct dose, that is what they want. But you want to have all of this stuff because this all needs to happen simultaneously. Okay, what if you have a patient that is hypernatremic and you can't give them hypertonic? We can give them mannitol, okay? The good thing about mannitol is it actually does not cross your blood-brain barrier, okay? It is a free radical scavenger. This actually helps take up all of those hydrogen ions and helps them urinate them out, which is great, especially when you're looking for inflammation. It can also help with your blood gases as well, because we don't want to have other issues. So this is another great thing to be able to give them. I will say lately, a lot of neurologists have sort of gone away from using mannitol, but it will be used if, say, they're still herniating after hypertonic, we will give them mannitol. And then there are other uses for it as well. This always needs to be given with a filter. It needs to be kept in a warm area. It can crystallize, and we don't want those crystals to go into our patients. So make sure you always have a filter on it. Make sure it's always coming out of a warm place. We typically keep ours in a incubator, thank you. Why I couldn't remember that word, couldn't tell you. But we keep ours in an incubator at all times and always give it with a filter. Okay, so mannitol, how does it work? Plasma expansion, then this reduces your blood viscosity, which then increases your cerebral blood flow and increased oxygen delivery. Important, right? We want the brain to get oxygen. The brain gets the blood, gets oxygen. As we learned, it's about 15 to 20% of your resting cardiac output. Okay, so a couple other therapies, right? GI protectants, these are all pretty important. We also learned that patients with TBIs can actually have delayed gastric emptying. So let's say we have a patient, we'll just say a Frenchie just because I really like them. Your Frenchie has a TBI, it's on its side. Frenchies already have delayed gastric emptying issues. Now they have a TBI, now it's more delayed. Now your patient's stomach is getting really big and it's on its side. And then it regurgitates and then it aspirates. So you want to make sure you're getting all these things on board with your patients. Pain medications, methadone, hydro, buprenorphine, depends. Always doctor dependent, always dose dependent from the doctor. This up here is your cat and your dog. These are the CSU pain scores. These are actually really good and very helpful to be able to assess patients' pain. When they have a TBI, you can't always assess them, but it is nice to have it when you are able to assess them as well. Some other therapies as well. Keppra, the favorite drug at the AMC if you have any type of neuro issue. This should be given every 8 hours for it to be most efficacious. It is, in human studies, we've actually found it to be brain protective. So yes, maybe this patient isn't seizuring, but we don't want it to seizure, right? Because that's gonna hurt your brain even more, but it's brain protective, right? So why not at that point? Again, doctor dependent. Very safe drug, minimal side effects, minimal concern for hepatopathy as compared to other anticonvulsants. So that's why this is a first go-to. Okay, other therapies. Steroids, controversial. Steroids are contraindicated in these patients, but There was a large human study there's actually 3 crash studies. This was the first crash study. They had 10,000 patients randomized to receive methylprednisone or a placebo. We learned that it increased the risk in death in the treatment group. So yes, it is contraindicated. Are some doctors still going to give it? Yes. It's doctor dependent, and it just depends on what's happening with your patient. The other thing with steroids, it can lead to hyperglycemia. As we also learned, hyperglycemia can also have worsening prognosis for our patients. So it's always going to be very much doctor dependent, but we do have a few studies out there saying that steroids aren't indicated in these guys. Okay. Other things, this is crash 3. Tranexamic acid is an antifibrinolytic. We also want to give this. So as we think about it, right, we have potentially blunt or penetrating wounds. We don't want our patients to bleed. This will help that. So these crash studies are actually really interesting when you get into them and truly read them. We don't really want our patients to bleed out, so it's really nice to have this available. Okay, I think we have a time for a case, which is actually a friend of mine, my friend's dog, so it's a fun case for me. Leonardo, he presented, he was bitten in the head by a large dog, or if you work in an ER, a BDLD, big dog, little dog. He came in with a lateral periocular swelling in the left eye, scleral hemorrhage in the left eye, bruised and swollen palpebrals, and some abrasions as well. He came in, everything looked pretty normal for him. He was QAR to dull. We placed an IV catheter, and we got our venous blood gas. If I were to look at this, I would say he has, well, actually, you guys tell me. You just all learned about it. Anybody can tell me what's going on here? I'll give everybody a minute with it. What? Anybody? Yep. What else? What? Base excess, yep, low base excess. Yep, low bicarb. What's that? Abnormal, normal, high, low? Okay. Close to the high end of normal, true. Okay. And then what about our pH? Low, okay. So we have a low bicarb, pretty much a normal CO2, and a low pH. Yes, nice work. Primary, so primary metabolic acidosis. Also, the other thing to note, sodium normal, important here. BG is high. I would say for him, we know that stress can increase your glucose, so this is pretty high, but let's see what happens with him. Okay, so we performed some diagnostics. We did a fluorescein stain, 3-view chest rads. Blood pressure was high normal, right? And on his POCUS, he had focal B lines and some irregularity in his lungs as well. Okay, but nothing too crazy. We're okay with it. Some initial treatments, placed an IV catheter, gave him my favorite drug in the entire world, Serenia. Methadone, hypertonic, and also Keppra. We loaded him up on Keppra, right? Just some brain protection. Always there to be helpful. Continued treatment. He was on fluids. We gave him pantoprazole. More Strenia. And then we kept lubing his eyes, right? Just in case his eyes are a little big, we want to make sure we can blink. And we gave him then also some Buprenex, and we gave him oxygen. We put him in 40% oxygen just to make sure he could still perfuse his brain. With some B-lines, we were worried potentially about some pneumonia, so we just wanted to make sure. He didn't fully need it. His pulse ox was about 92, 93 on room air, but we wanted to make sure that he got it just in case. And within an hour, he was back up to 96, and we still left him in there for about 24 hours as well. I didn't have another picture of him, so I just used this cute dog from a couple weeks ago. We continued to monitor his heart rate, temperature. We left him on telemetry, his respiratory rate. We did monitor his level of consciousness, which was great. He stayed QAR the whole time, and his blood pressure, which stayed about normal the whole time, and his pain score. He came in pretty quickly to us initially after his bite. And so we were able to get in there pretty quickly. If he had waited, it would have been potentially a worse outcome. And then he went home, and he's doing great, and he's running around with his mom and his new little brother. So, and we just sent him home on Keppra as well, just to help him out. Questions?